name is Kent. I'm an obstetrician and gynecologist based in Sydney. My particular interest in this topic is acupuncture for chronic pelvic pain. As you can see on the photo of the first slide, it has been used in the past in the metal acupunctures back thousands of years ago in China. Then you can see different shape of these acupuncture equipments. Nowadays, we use the disposable one. In the old days, they used the acupuncture. They have to use the fire to sterilize it, wash it. They have to maintain their gears. But nowadays, for the infectious control purposes, all disposable. Now, just before I go into my work, I want to give everyone a bit of background of what acupuncture is for those people who is not familiar with acupuncture. So it's a key component of traditional Chinese medicine. It is a technique that aims for balancing the flow of energies, also known as qi. Can everyone hear me? Yeah. And this energy flows through the pathway in the body from the Chinese medicine theory. And these pathways is what we call meridians. As you can see here, in a man or woman, you have many meridians. You have 12 meridians, main meridians in total. Each color represents different meridians. You have 6 yin meridians and 6 yang meridians. Those meridians is considered a pathway that can flow through those energies. Now, the traditional Chinese medicine believes by inserting those needles, these acupuncture needles, into the specific points, as you can see those dot points on the pathway, along those meridian pathways, this energy flow will be rebalanced. They believe whatever happens in the bodies, in the meridian, in the pathway settings, it gets blocked. When it gets blocked, your qi doesn't flow through smoothly. Your energy gets blocked, and that's how you get sick or that's how you feel unwell. By doing the needlings, the energy flow will be able to flow through. If you imagine all this meridian pathway is the water pipe, and then a part of it is blocked, then it's just like, the plumber just trying to, make sure the toilet, is going smoothly, the plumbing. So by doing the acupuncture, you will unblock those energy blockage and you make the qi flow through again. And that's why normalizing again. That's the theory behind, okay? Then the Western practitioners, view the acupuncture point as the place to stimulate nerves, muscles, and connective tissues. As you can see from the previous slide that, those meridians running along the surface of the skins. Some of them running along with our anatomy, the ulnar nerve, the radial nerves, and so forth. So they believe these points are placed to stimulate the nerves, muscle, and connective tissues. So acupuncture can treat many diseases or conditions. For example, nausea, hyperemesis, insomnia, anxieties, allergies, asthma, sciatica pain, osteoarthritis pain, headache, neck pain, back pain, and so forth. Of course, including the pelvic pain, which is my main interest. Then why do we focus the acupuncture on analgesia? Well, the reason is acupuncture has a remarkable effects on pain clinically, and it has been used for more than 3,000 years from pain control point of view. And most importantly is a level 1 evidence of clinical studies. If you see thousands of papers about acupuncture analgesia. All right. Just give you a little example here. This paper has been done like 20 years ago. It's been done years. All those papers study acupuncture. It says acupuncture used to treat painful conditions or disease. And as you can see, 80% of acupuncture applications they realized that it's all used for pain. Back pain, joint pain, neck pain, headache, migraine, recurring pain, allergy or arthritis pain. It can also be quite useful for anxiety or insomnia. A clinical setting-wise, is widely used for pain. Then back to the evidence-based medicine, the current theory of electroacupuncture analgesia. Professor Han Ji-sun in China proposed the endorphin theory. This is 30 years ago, that electroacupuncture stimulations of different frequencies will result in different subtype of receptors of opioid mediating the analgesic effect. In his studies, he realized that if you stimulate with electroacupunctures and then you check the level of endorphins, it's actually quite high. As everyone knows that endorphin is a hormone that really is the natural painkillers in our bodies per se. Then there are different sub-endorphins. It released by the hypothalamus and pituitary gland in response to our pain and stress. These good peptide hormones can create general feelings of well-being. Many things can induce, endorphin, and the most study of endorphin is beta endorphin, which it's been proven that electroacupuncture can give you beta endorphin as well, along with other subtype endorphins. Now, if you do exercise, if you do meditations, if you play music, if you have a good laugh, if you have a sun exposure under a UV light or have sex, they can all induce your endorphin in the bodies in different levels. And most importantly, acupuncture can do that too. And this has been proven that endorphin theory is true back then. Then there's in addition to endogenous opioid peptides, there's another professor that's been doing this study for acupuncture for a long period of time, Professor Lin Zhaogen. And his team found that serotonin also plays an important role in acupuncture analgesia. The team is based in Taiwan. So they realized that from the animal models to the human models, the acupuncture can also release serotonin. As we know, serotonin is good for analgesic effect as well. So the paper was back in 2004. This is a particular slide just showing you that how it works in terms of acupuncture. You can see here, you have the needling here on the hand or the foot. You get this muscle stimulation by manual acupuncture. That's what MA stands for. Or electroacupuncture, that's what EA stands for. Whatever stimulation through acupuncture, then you'll release this ATP, adenosines, and then go to the adenosine A1 receptor and pain inhibitions. So usually what happens is once you have the stimulations on the surface of the skin or a little bit deeper to the muscle area, then sometimes here we're running through a little bit medial nerve, ulnar nerve through the hands. Then you might stimulate a bit deeper to the nerve area. Whatever happens, the stimulation will pass through, go to the dorsal horn of the spinal cord, go up, send a signal up to the hypothalamus, and hypothalamus release all those opioid peptides and give you this effect of COX-2 or anti-inflammatory effects to give you the pain inhibitions, okay? And also they find during this pathway, the serotonin's role in acupuncture anesthesia in the spinal cord from the rat, they can detect that as well. So it's released is actually in the spinal cord fluid. So then the evidence is humongous that is a possible neurophysiology mechanism under the acupuncture analgesia. Then it comes to my research, because I am a gynecologist. I've seen many patients in my room and clinics about the pelvic pain. Most of them becomes chronic pelvic pain for a lot of reasons. Then I run out of the option of conservative management, medical management, surgical management. Then that's why I look into acupuncture. And I realized that acupuncture is actually, after the systematic review and meta-analysis, we find a good result on chronic pelvic pain for both men and women. So this is the paper I published last year. So the systematic review and meta-analysis, we use PubMed and M-based data from 2011 to 2022 without any language restrictions. We use the SHRICTA criteria. It's a criteria very similar to the randomized control trial, except it's a standard reporting interventions specifically for acupuncture. The reason we choose 2011 to 2022 is because this SHRICTA criteria only being published since 2010. So all the trials who gone from 2011 were meeting this SHRICTA criteria. So it's standardized process, easier for us to do a review and a meta-analysis. Then we have found 17 studies, including English and other language. In these 17 randomized control studies, they have 1,455 patients. They use two systems among those papers. One is the VAS score systems. One is the NIH CPSI systems. The VAS score is a visual analog scale and numerical rating scale systems. In these systems, including men and women in the randomized control trial. For the NIH CPSI is the National Institute of Health Chronic Prostatitis Symptom Index. This particular pain score is for men only. Then in the chronic pelvic pain, out of these 101,455 patients, we have 867 females, 588 males. Then if you divide them into the group, the acupuncture group and the intervention control group, 728 people is with acupuncture group. This group including electroacupuncture, manual needling acupuncture, moxibutions, abdominal acupuncture, laser acupuncture, or catgut implantation acupuncture. In the 727 patients with control interventions could be including the standard care, Western medications, endone or other kind of medications, traditional Chinese medicine medications, physiotherapy, and sham acupuncture. Sham acupuncture is the control acupuncture, as in not really acupuncture, but it mimic like acupuncture to try to compare the effect. Then this is a summary slide of all the 17 papers published in this time period, and to give you whether the randomized control papers, the trials have low risk of bias or high risk of bias, and you divide it in different pillars in terms of randomization process, deviations from the intended interventions, missing outcome data, measurement of the outcome, and selections of the reported result on big 5 categories and overall summary. You can find out most of them are actually low risk bias, so you can consider as a good quality paper. Some of them have some concern, some of the components are high risk, but overall, all in all, most of the papers out of the 17 is acceptable. Then the meta-analysis of 7 studies evaluating the NIH CPSI pain score. This is mainly talking about the main pelvic pain. They realized the effect of acupuncture is actually very consistent. Doesn't matter the electroacupuncture group or manual manipulated acupuncture group or catgut implantations. They are all effective, which means they can provide significant clinical difference of analgesia effect for pelvic pain. Then if you look at the other 10 studies evaluating VAS scores, the same thing. Electroacupuncture is working well, manual acupuncture is working well, moxibution is working well, abdominal acupuncture is working well, acupuncture is very effective. Then laser acupuncture is showing not effective. There's no difference. But all in all, if you put them all together, it's still any type of acupuncture in everything in the meta-analysis, it looks effective. Now, the subgroup analysis of those 10 studies, including men and women, about the VAS score, not just the chronic prostatitis, it can be a lot of things causing your pelvic pain. That subgroup analysis shows that if you compare acupuncture to the standard care, it's effective. if you compare acupuncture with the traditional Western medicine by giving them opioid-like medications, it's effective. Acupuncture is effective, better than Western medicines. If you compare them to traditional Chinese medicine, the herbal medicines, the same, acupuncture is effective. However, if you compare the physiotherapy along with the acupuncture, they find that there is no difference, which means that physiotherapy and acupuncture can both, manage the chronic pelvic pain. The next slide. This is the most important slide. This slide tells you that if you look at the subgroup analysis of two different score systems, the NIH-CPSI score is the chronic pelvic pain for prostatitis. The VAS score is for generalized chronic pelvic pain. Doesn't matter which scores you're doing. If you look at acupuncture as add-on therapy, for example, do your traditional way of managing your chronic pelvic pain plus acupuncture is much more effective rather than not doing acupuncture. So acupuncture is effective in the add-on therapy for both groups. Doesn't matter if it's a VAS group or is a NIH-CPSI group. Now, if you look at acupuncture as a monotherapy, as in the person just have a chronic pelvic pain, there's nothing sinister there, there's no malignancy pathology going on, then they go for a acupuncturist treatment with acupuncture. Actually, monotherapy is quite effective too. For the chronic prostate pelvic pain problem or just the general chronic pelvic pain problem, okay? So this slide just tells you acupuncture can be the add-on therapy for your chronic pelvic pain patients. It can also be the monotherapy, all right? Now, just a little bit interesting talk about my chronic pelvic pain, because most of the women coming with chronic pelvic pain, I'm a gynecologist, I deal with women's pelvic pain. There are a lot of reasons. It can be fibroid, it can be other things, it can be adenomyosis, but usually speaking, it's the endometriosis causing the problem. Then you have different stage of endometriosis. You can have a very severe form of stage 4 endometriosis, needing surgery to fix it, or you can have a not so severe form of stage 2, stage 1 endometriosis, and you can get away with the hormonal treatment, let's say the oral contraceptive pills, combined pills, or some sort of a hormonal intrauterine device, hormonal IUD can treat this kind of women. But all in all, some of women, after the surgeries, after you treat them all, most of the time, the pain is gone, but there's always a small percentage of women when they come back, then the pain is still there. Then 2-3 years later, after the surgery, you treat it with hormonal treatment, you give them a surgery again, you repeat it, and then you find that nothing is there. There's most of the endometriosis that's visible is all removed by your previous surgeries and treated with hormonal. There's nothing there, and it looks like these beautiful pictures like this. Then they still come back with pain in tears, their chronic pelvic pain, can't have sex with their partners and so forth, and think no one believes them. Those are the patients that I find that really struggle, and that's why I've done this paper review. And clinically, when I use acupuncture to train them for the last few years, based on my clinical experience, is actually working for them. So in a nutshell, there are different ways of treating this chronic pelvic pain, and acupuncture can be one of alternative measures to help. It can be the add-on therapy, it can be a monotherapy alone. So conclusions, acupuncture has beneficial effects on the pain management for chronic pelvic pain for both men and women. Acupuncture can be used as a monotherapy or adjunct therapy. Endometriosis-related pelvic pain, the course of treatment usually should be 4 weeks to 6 months. Because they are chronic problems, usually 6 months is usually quite effective, but minimum 4 weeks, because as everyone knows, the period comes in every 4 weeks. If you don't treat it 4 weeks, you don't see the effect for the next cycles, period cycles. That's it.
Hello everyone, let me introduce myself. My name is Hermina Purwokerto from University Purwokerto. We conduct the research in 2020 to find out the ERAS or SC method with fast recovery, modifying the dose of the low-dose spinal anesthesia. Yes, my research is A comparison between low-dose spinal anesthesia and non-low-dose spinal anesthesia to hemodynamic and ephedrine use during cesarean section in Hermina Purwokerto Hospital. In this research, my lecturer is Susiodi Dewi Karita Minahartina in the affiliation of Department of Anesthesiology Medical Faculty of Universitas Muhammadiyah Purwokerto and Department of Biochemistry Medical Faculty of Muhammadiyah Purwokerto. The first is background. Yeah. Sexual cesarean is surgical procedure to deliver the fetus by opening the abdominal wall and uterine or vaginal wall, or a hysterectomy to deliver the fetus from inside the uterus. In the World Health Organization has said indicator of SC is 5 until 15 for each country. In the fact number Casein section is continue increase the last 15 years until it has now reaches 21% worldwide. Its testimonial, this figure will continue increase 4% every year. The brown in withdraw the previous recommendation of a 50% cesarean rate in June in Indonesia. The presentation of cesarean is 17%. Cesarean is procedure, request anesthesia techniques. Anesthesia techniques are broadly divided into two types, namely general anesthesia and regional or local anesthesia. There are several techniques designed to prevent hemodynamic disorder in pregnant women undergoing SC surgery, one of which is by administering ephedrine. The objective for my research in the one general objective to find out whether there is difference between low-dose spinal anesthesia and non-low-dose spinal anesthesia on hemodynamic and the use ephedrine during SC surgery. The special objective is to know the difference between low-dose spinal anesthesia and non-low-dose spinal anesthesia on the use ephedrine and blood pressure during SC surgery at Hermina Hospital Purwokerto. The second is to find out the difference between low-dose spinal anesthesia and low-dose spinal anesthesia, use the ephedrine and pulse frequency during SC surgery at Hermina Hospital Purwokerto. And the third is to determine the difference between low-dose spinal anesthesia and non-low-dose spinal anesthesia on the use of ephedrine and mild arterial pressure during surgery at Hermina Purwokerto. The population for the research is all pregnant patients undergoing SC surgery at Hermina Hospital Purwokerto. The sampling technique is simple random sampling. Is sampling randomization resembling a lottery, so that each member have a population has the same opportunity to become a sample for this research. Sample calculation using G-Power software. The software can be used to calculate sample size based on effect size, significance level, statistical power, and group ratio. The assumption used are medium effect is 0.5, significance level is P 0.05, statistical power is 95%, and equal group ratio. The total sample size was 84 samples or 42 samples in each group. The sample has inclusion criteria. The first, the patient underwent surgery between November until January 2020. There are medical record patients with SC surgery using low-dose spinal anesthesia or non-low-dose spinal anesthesia technique. Patient in healthy condition without disease that affect the body hemodynamic stability or base the ASA2 classification. The exclusion criteria: medical records are damaged or illegible. The patient is known to have a disease that will significantly affect the patient hemodynamic, such as preeclampsia, heart failure, since before pregnancy, kidney failure since before pregnancy. The patient is known to be carrying a fetus that will significantly affect the mother hemodynamics, such as esophageal atresia, which causes polyhydramnios. The characteristic of the subjects. In the one, comparison, use low-dose spinal anesthesia and non-low-dose spinal anesthesia group between use ephedrine. It's two group. In the group 1, low-dose spinal anesthesia is 0 get ephedrine, and which is do not get is 42, mean 100% group of LDSA or low-dose spinal anesthesia don't get ephedrine. But different things in non-low-dose spinal anesthesia is 6 among population 42 get ephedrine is means p-value is 0.026. P-value significant. And second, hemodynamic comparison, low-dose spinal anesthesia and non-low-dose spinal anesthesia group is use the Smirnov method. This method was chosen because the amount data was more than 15. Level group of LDSA or low-dose spinal anesthesia is main arterial pressure indicate distribution interpretation is normal. The table above show that only mean arterial pressure variable in the low-dose spinal anesthesia group has a normal distribution, while the other variables have a normal distribution. And the next, comparison of hemodynamic of low-dose spinal anesthesia and non-low-dose spinal anesthesia with the Mann-Whitney test. In the first is hemodynamic is pulse. Pulse with low-dose spinal anesthesia has median 18 and non-low-dose median anesthesia has median 86. Its p-value 0.001. And second, systolic blood pressure has a median in low-dose spinal anesthesia group is 120 and non-low-dose spinal anesthesia is 110. Diastolic blood pressure is 80 on group low-dose spinal anesthesia and 70 in non-low-dose spinal anesthesia. In main arterial pressure is 90 on low-dose spinal anesthesia and 82.5 in non-low-dose spinal anesthesia. Next, the discussion. The discussion of comparison of ephedrine used between the low-dose spinal anesthesia group and the non-low-dose spinal anesthesia group. The result of this study found that patients in the low-dose spinal anesthesia group did not receive ephedrine. Meanwhile, in the non-low-dose spinal anesthesia group, 14% received ephedrine. The result, the analysis, the difference proportion is statistically significant. This shows that patient with non-low-dose spinal anesthesia group has more unstable hemodynamic condition, thus requiring ephedrine intervention. This finding also strengthened the result. The study also found the non-low-dose spinal anesthesia group have a hemodynamic condition. The result is aligned with a study conducted by Ahmed in Egypt. One of the results of this study is use ephedrine was effective in keeping the patient hemodynamic stable in patient received spinal anesthesia. Spinal anesthesia is prone to hypotension and occurs early in sensory motor block because the spinal nerve roots in the sympathetic nerve fibers and sensory fibers are unmyelinated. Ephedrine administration will maintain arterial pressure by increasing cardiac output and heart rate as adrenoreceptor activity. The second, discussion of hemodynamic comparison between the low-dose spinal anesthesia group and the non-low-dose spinal anesthesia group. The result of the study significantly the greater median heart rate of low-dose spinal anesthesia group. It was also found as significant. And also in the non-low-dose spinal anesthesia group has a significant lower median systolic blood pressure, had a significantly lower medial diastolic pressure, had a significantly median mean arterial pressures, and then the low-dose spinal anesthesia. The results are aligned with study conduct by Chanswonsky in Canada. One of the results if the study found the administering low-dose spinal anesthesia was effective in maintaining stable hemodynamic and patient receiving spinal anesthesia. Similar results were also reported in the research conducted by Almeida in Portugal, who had more stable hemodynamics, so they need fewer vasopressor agent or did not need them at all. For the conclusion, the cesarean patient with low-dose spinal anesthesia had more stable blood pressure condition, so that is the theory there was no to receive the additional ephedrine during SC surgery. In the second, patient with non-low-dose spinal anesthesia will have a median pulse that's significantly greater than SC surgery patient with low-dose spinal anesthesia. And the third, patient with non-low-dose spinal anesthesia had a significantly lower median arterial pressure than SC surgery with low-dose spinal anesthesia.
Okay, thank you everyone. I want to introduce myself. My name is Erika. I am from Indonesia. Thank you. I am very grateful to all committee for being given a valuable opportunity to participate in this event. And I feel very blessed to join with this event. But I'm sorry before my English is not too good, so I will try. Okay, my research about sexual violence against girls, and the situation right now is HAO indicates that globally about 1 in 3 of women worldwide have been subjected to either physical and or sexual intimate partner violence or non-partner sexual violence in their lifetime. As many as 753 million women who married from the age of 15 experienced physical and sexual violence by their partner at least once since the age of 15.3 years. That means that 1 in 4 women aged 15 and until 19 years experienced violence by their partner. And the situation in Indonesia, at least 26 per day girls experiencing sexual violence in Indonesia in 2022. And it has increased very sharply compared to previously at 20 and 21 around 11 girls per day. And we know sexual violence against girls is a frightening problem in many countries. And I want to say about the untold story of several victims of sexual violence against girls, child marriage, and sexual abuse. This research aims to explore the phenomenon of sexual violence experienced by girls, and this is a qualitative research. I'm sorry. And the time is November 2023 until January 2024. The informant 13 until 18 years old. And data resource from NGO Women Crisis Center and Department of Women Empowerment and Child Protection. The triangulation data from parent and companion. I'm sorry, this is, I'm sorry, I was edited. Okay, I want to convey except my in-depth interview with my informant. She said, after I became pregnant, my parents married me with my boyfriend. At first, he refused, but he forced to agree because my pregnancy was getting bigger. I lived with him in the rented house, but he was almost never at home. I work from 8 a.m. to 9 p.m. to get money. It's so difficult for me because I am pregnant. This is a very young girl, 15 years old, weight 34 kilograms. Number two, I asked two girls, 16 years old. She's a widow. One day, I didn't have money to buy instant milk for my baby, and my husband never cared about it. So I was basking on the main road, singing in the road. I got money and I used it to buy milk, to buy diapers, and I gave to my mother to buy some food because that day there is no food at home. And I asked her, do you love your baby? And she said, yes, I really love it. And I don't care even if his father is irresponsible. I will do anything for my baby. And her sentence is so touched my heart. The next participant, I don't want to continue my study. I am embarrassed. My mother and my grandmother don't have money. I just want to work to help them. This is 11 years old, elementary school, and after an attempted rape by his father. And I asked two fathers, another informant. One day I saw him pointing a knife to my doctor. I was angry and almost loss of control. I reported to the police. He is a father, 62 years old, with daughter who get unwanted pregnancy and married at 16 years old. I'm sorry. I saw another informant. She's a 15 years old girl with very thin body, school dropout, and living in the village with her mother. When I asked, why do you look so sad and so thin? And she said that she was really sad, don't feel hungry and feel very difficult to eat. I think that she was sad because of sexual harassment that adult man did to her. But I was surprised when she answered, I really miss him. And he promised to marry me after he got out of prison in 6 years. He said he had broken up with his girlfriend and would definitely choose me. I believe he will marry me. And I asked, why do you love him so much? He has hurt you and abused you and raped you, so why? Is he very handsome or romantic guy or what? And she said, no, he doesn't handsome, but he's a good man, very smart and very religious man. So I really love him. It's very sad because the girl is very innocent and he don't understand that the man is a bad guy, and yeah, it's she don't understand about it because it's very innocent and she's just a young girl. And from the fact we get analyze that they experience sexual violence from their boyfriend or father. They had low knowledge about sexual and reproductive rights, and those at risk of sexual violence are children or adolescents with low education, low knowledge, and poverty. And the reason of child marriage because of get pregnancy before marriage. The purpose of pregnancy is to cover ignominy. Free sex is ignominy in Indonesia. The girls get pregnancy with poor physical and psychological condition, high risk of pregnancy and labor because of their young age and chronic lack of energy and very thin body. Try to hiding the pregnancy and never visit to antenatal care, and unable to care baby and unable to breastfeed it. Girl victim of sexual violence have to face reproductive health problem, sexual problem, psychological problem, education problem, economic and social problem in the community. And the problem is not only faced by survivor, by himself, by herself, but also her family. So this requires commitment from various sectors to prevent sexual violence and also help victims to be able to achieve better life. I think we should to promote like sexual education is needed for children and teenagers. The girls must understand sexual and reproductive health right and understand the consequences of free sex or premarital sexual relation, and uh, and uh, if happen rape or sexual violence, the girl must don't be afraid to speak up. We believe everyone deserves a better future, no matter the mistake they've made or the two problems they faced in the past. Everyone need the better future for their life. And then this is my references. Maybe it just I can share with you all. And thank you very much.
Good afternoon. Me, Dr. Raji Sultana from Bangladesh University of Health Sciences, welcome you all in my presentation. The topic of my discussion is hepatitis E virus, a potential risk factor for morbidity and mortality in Bangladeshi pregnant women. First of all, I want to focus the background information of my study. Hepatitis E virus emerges as the most frequent cause of acute liver disease that is still a major public health problem. According to World Health Organization report, approximately 20 million of global people suffer from HIV infection every year, with 3.3 million symptomatic cases and 60,000 recognized HIV-related deaths. 8 distinct HIV variants have been recognized so far, but 4 are common infecting humans. The infection is commonly transmitted through fecal oral route, hence linked to a large waterborne epidemics, especially in low and middle income countries like Bangladesh. Here you can see in the right side the picture depicting the stagnant water in the busy street and household areas because of heavy rainfall and sudden flooding. Patients seldom present signs symptoms of hepatitis followed by spontaneous recovery because of self-limiting nature of the infection. However, moderate to severe morbidity is documented in pregnant women. There remains scarcity of data on hepatitis C viral load, the immune responses, and its genotypes. However, the influences of all these factors on maternal outcomes in Bangladesh remain unexplored. Among the 4 common genotypes infecting humans, genotype 1 and 2 are most prevalent in countries of Asia, Africa, and Latin America. Genotype 3 in the United States, Europe, Australia, Japan, New Zealand, China, and genotype 4 mainly confined in China. It is an overview of the hepatitis C virus. Hepatitis C that represents the natural history of hepatitis C virus infection. Hepatitis C virus infection, most of the cases appear as silent infection that ends with spontaneous recovery. Few percentage of cases develop acute symptomatic hepatitis that can proceed to fulminant hepatitis, leading to death. A number of cases can develop chronic hepatitis, especially in the immunocompromised individuals. Some of them recover spontaneously, and few develop cirrhosis and mild hepatitis. Some common clinical manifestations of the hepatitis C infected women are yellowish skin and conjunctiva, low-grade fever, nausea, anorexia, upper abdominal pain, dark urine, light-colored stools, and pruritus. Since most of the infections are asymptomatic, the symptomatic infection runs in a diverse spectrum of clinical courses, likely acute resolving hepatitis, chronic hepatitis, that is most common in immunocompromised individual, fulminant hepatitis. Fulminant hepatitis is a severe form of hepatitis that develops hepatic encephalopathy within 4 weeks of infection, characterized by mental changes, progressing from confusion to stupor and coma, resulting from huge impairment of liver function without any history of pre-existing liver disease. Hepatitis C virus may develop few extrahepatic manifestations like pancreatitis and hematological disorders, likely anemia, pancytopenia, thrombocytopenia, renal disorders, and some neurological manifestations like Guillain-Barré syndrome and meningoencephalitis. Fulminant, and again, it can develop fulminant hepatic failure, that is an end-stage liver disease, resulting from total impairment of liver function and commonly associated with cerebral edema and disseminated intravascular coagulation. Some studies previously carried out in Bangladesh by a group, Garli et al., demonstrated moderate to severe morbidity is documented in pregnant hepatitis patients, leading to mortality. That means maternal mortality happens in 19 to 25% cases, and in infant mortality happened 7 to 13% cases, and 58% of all deaths from hepatitis are attributed with hepatitis E virus. Same group in the little letter reported 69% death were in female, and miscarriage and perinatal mortality was higher in 2.7 times higher in the pregnant women than non-pregnant women. Sugitani et al. Little earlier documented that 25% of the all acute hepatitis are attributed to hepatitis E virus infection, and the confirmed cases had high serum alanine transaminase and aspartate transaminase levels, 2 most important liver enzymes that are associated with liver injury, and all of them had HEV-specific IgM and IgG antibodies, and viral isolates are all genotype 1, which is prevalent in South Asia. However, this study was undertaken with a much broader objective to determine the role of hepatitis C viral load in pregnant and non-pregnant patients, and to determine the immune responses in pregnant and non-pregnant patients who are infected with hepatitis C virus, as evidenced by HEV-IgG avidity assay of liver enzymes and coagulation parameters as indicator of the severity of the morbidity that explores its association with morbidity and mortality. and to identify the genotypes of the HIV infecting pregnant patients, and finally to find out maternal outcomes following the HIV infection. Now, materials and method. Subjects of this study were enrolled from three large major hospitals of Dhaka city, Bangladesh, namely Dhaka Medical College Hospital, Bangabandhu Sheikh Mujib Medical University Hospital, two large public hospitals in Dhaka city, and another private hospitals under Bangladesh Diabetic Association named as Bangladesh Institute of Health Sciences General Hospital. Now, recruitment criteria of this subject. First of all, inclusion criteria. Pregnant and non-pregnant women with signs and symptoms of acute hepatitis having age ranging of 18 to 50 years with high serum bilirubin and high serum alanine transaminase levels were included in the study. Patients positive for hepatitis A, hepatitis B, and hepatitis C after screening by enzyme-linked immunosorbent assay were excluded from the study. Again, non-consenting pregnant patients with hepatitis and any other comorbid condition such as cancer, mentally and physically challenged individuals are also excluded from the study. Sample stratification was done according to this algorithm. 153 suspected acute hepatitis cases were enrolled initially after exclusion of 32 patients who were positive for hepatitis A, hepatitis B, and hepatitis C. 121 patients who are positive for HIV, IgM, and/or IgG were finally enrolled in the study. 78 cases had HIV, IgM, and IgG. That represents the 50% of the total sample of the study. And viral copy was detected in 62 cases, and sequencing done in 32 cases. Among them, 50% were pregnant and 50% were non-pregnant cases. Laboratory methods. After taking informed written consent from each participating patients and maintaining all the safety precautions for blood collection, 4 ml of blood was collected in a plain Vacutainer tube that was transported to Institute for Developing Science and Health Initiatives Laboratory, a renowned research institute laboratory, and maintaining cold chain. Blood was transfused at 3000 RPM for 10 minutes at 4 degrees centigrade. Serum was separated and aliquoted at -40 degrees centigrade. Laboratory analysis starts with estimation of bilirubin, alanine transaminase, aspartate transaminase, alkaline phosphatase, and albumin assay, albumin. And at the same time, hepatitis E, IgM, and IgG were screened by enzyme-linked immunosorbent assay. Patients who were positive for HIV, IgM, and IgG were subjected for molecular analysis. RNA was extracted from HIV, IgM positive serum. That was followed by real-time reverse transcription quantitative PCR for determination of viral load and reverse transcription PCR for generation of cDNA. That was followed by PCR application of open reading frame 2 region using a specific primer. And after gel documentation and purification of PCR product, DNA sequencing was done for identification of genotype. Now, results. Actually, the result, it is a table for showing the HIV, IgM positive and negative cases that has been stated in this table. Socio-demographic status. This table showing the socio-demographic status of the HIV, IgM positive and HIV, IgM negative patients, hepatitis patients, illustrating the potential risk factors for HIV transmission, where shared facilities for living arrangement and unsafe drinking water was strongly associated with the HIV, IgM positivity. Shared facilities for living arrangement and unsafe drinking water were strongly associated with the HIV, IgM positivity. Sorry for slide. Okay. Another factors for the HIV transmission, and these are potential risk factors. I have received no significant result from this table, and this table showing the age and liver function status among pregnant and non-pregnant study subjects of real-time PCR positive patients, that showed that significantly high values were observed for serum bilirubin and serum alkaline phosphatase in the pregnant patient, but significantly lower values was observed for serum albumin level in the pregnant patient than their non-pregnant counterpart. The graph path which I'm showing the serum ALT and AST level in early and late acute stage of hepatitis, irrespective of pregnancy status. Showing the serum ALT and serum AST level were significantly higher in the early acute stage of the hepatitis than the late acute stage of hepatitis. The second graph path which I'm showing the log viral copy number and log IgG sample index value for hepatitis E in the early and late acute stage, irrespective of hepatitis. The log viral copy number was significantly higher in the early acute stage of the hepatitis. Conversely, log Hep-IgG sample index value was significantly lower in the early acute stage of hepatitis. Now, when we compared log viral copy number between pregnant and non-pregnant patients in early and late acute stage, then we can see the log viral copy number was significantly higher in the late acute stage of hepatitis in the pregnant patient than its non-pregnant counterpart. Again, when you compare log IgG values between pregnant and non-pregnant patients in the early and late acute stage, the log Hep-IgG values are significantly lower in the pregnant patient in the late acute stage than its non-pregnant counterpart. Now, we evaluated Hep-IgG avidity assay in pregnant and non-pregnant women. And avidity assay, it is a numerical constant that represents the association strength between antigen and antibody that was performed by minor modification of conventional ELISA method using 7 millimolar urea solution in the analysis assay method, and it was calculated by using a standard formula. When we compared antibody avidity index between pregnant and non-pregnant women, pregnant women exhibited significantly lower avidity index than its non-pregnant counterpart. That indicates that much more cross-reactive antibodies are generated in the pregnant women that renders little neutralizing effect on viral load, enhancing the morbidity and mortality status of the pregnant women. The phylogenetic tree was constructed for randomly selected 15 Hep isolates. All the isolates form a single cluster with the genotype 1. And however, all the isolates in this study were genotype 1 variety. Now, maternal outcomes in HIV-infected pregnant women were in my study. 70% of the patients recovered spontaneously. Spontaneous abortion was found in 5% cases. Antepartum hemorrhage was also found in 5% cases. 2% exhibited intrauterine fetal death, and 9% exhibited preterm delivery. Stillbirth, the death of the baby soon after birth, was found in 2% cases. Acute liver failure and fulminant hepatic failure leading to death was found in 7% cases. These 7% cases was the representative of my 5% deaths of my study subjects of my study, five deaths of my study subject. It is the profile of the 5 patients died during hospital stay. Among the 5 death cases, 4 were pregnant, and all them have the age range below 25 years. And all the death happens in the late acute stage of the disease, except case 5. The biochemical profile of the patient, when we studied the biochemical profile, there's this raised biochemical profile was observed in all 5 patients, except albumin. Albumin was low for the 5 patients. Serological and molecular, sorry for interruption. Serological and molecular characteristics of the 5 patients showed that among the 5 patients, 3 had Hep-IgM negative. 3 were Hep-IgM negative, but all the 5 patients were Hep-IgG positive. Viral copy was detected in 2 patients only, and all of those were in genotype 1 variety. Sorry for the interruption. Okay. Coagulation profile of the 5 patients died during the study. This is actually it is the hospital record of the study. All the 5 death cases showed lower range of platelet count, but the prothrombin time, fibrin degradation product, and D-dimer, the coagulation parameters were high for the 5 patients, and the possible cause of deaths were fulminant hepatic failure and disseminated intravascular coagulation, and all the death happened in the last trimester, 3rd trimester of the pregnancy. Sorry, just to display, for better display, I just take time. Coagulation profile of the death cases versus survived cases. When you compared coagulation profile in the death cases and survived cases, then the death cases showed significantly higher prothrombin time, fibrin degradation product, and D-dimer value than the survived cases. The study may be concluded as compromised immune response was demonstrated in pregnant hepatitis patients as judged by low HB-IgG levels in late acute stage of disease. Low level of HB-IgG are assumed to render less neutralizing effect, resulting in higher viral load than that of non-pregnant counterpart, attributing severe morbidity in HB-infected pregnant women. Low IgG avidity index in HB-infected pregnant women justifies less elimination of the viral load, thus influencing the morbidity. Hepatitis E virus induced fulminant hepatic failure resulted in deaths of 5 patients. Here is our team members, Dr. Firdausi Kadri from ICDDIB. She is a senior scientist of mucosal immunology and vaccinology unit, and she is the renowned scientist in the biomedical research background, biomedical research field. And another identity, she was my PhD supervisor, and my joint supervisor was Professor Dr. Monjurul Karim from Dhaka University, and others Tawfiqur Rahman Bhuya from ICDDIB, Tariqul Islam, now working at Washington University, St. Louis, USA, Shubhabhat Kumar Sarkar, Umeå University, Sweden, and Dr. Kaisar Manur, now working as a professor in Military Institute of Science and Technology, Dhaka, and Dr. K. Jaman, senior epidemiologist of ICDDIB, and Professor Dr. Jahid Hassan. He is a professor of physiology and molecular biology, Bangladeshi University of Health Sciences, and me also. My study was supported by Institute for Developing Science and Health Initiatives. It is a state-of-the-art research platform for graduate and postgraduate students in Dhaka City, and founded by Dr. Firdausi Kadri, where I worked my research work, performed my research work, and another support from ICDDIB and Ministry of Planning, Government of Bangladesh. I express my heartfelt thanks and gratitude to the organizers of the second international webinar on gynecology and obstetrics, and their collaborators for selecting me as a speaker, and for providing me the opportunity to share my research work in this auspicious session. Thank you all for your patience hearing.
Hello, everybody. Thank you for having me here today. I would be starting by talking about the mental health condition in India of women and how assessing their gynecological issues is important, wherein I would like to introduce a new tool of measurement assessment, which is the OGDMS. So what we will be discussing today is the need for assessment, what the OGDMS is, its benefits, its limitations, and its impact on the current healthcare scenario. So the need for assessment is basically that currently, if you look at the statistics, around 40% of women who are diagnosed with PCOS or PCOD are going through major depression, major depressive episodes. So, and there's not much that is being done for them in the clinical setup. They might be taking help outside the clinic, so like seeking psychotherapy outside the clinic, or seeking psychiatric help outside the gynecological setup. But there's not much that is being done at the gynecology or at the healthcare setup, physical healthcare setup, basically. So because there is no time, or there is a lot of constraint when it comes to the diagnosis of mental health conditions in a gynecological setup. So there is a significant lack of measurement tools, especially for the Indian women. There are a few tools available that are for a global use kind of a thing, but specifically targeting Indian women and their requirements is something that has not been addressed so efficiently. So because there is a lack of measurement tools, and because there's a lack of the assessment, basically, these problems tend to go under the surface. So there's not much that gets done about it. That is the reason why me and my team, we worked on devising a plan, or we devised a tool, which is the OGDMS. The OGDMS stands for the Obstetrics and Gynecological Distress Measurement Scale. What it is it's a 20-item self-report test, like a paper pencil test, and its components are basically physiological distress, psychological distress, and environmental distress. So when I say distress, it is a basic undercurrent of the problem. So it does not, the test will categorize, and the test will measure which area of the person is getting affected the most, or what aspect of their life is being more distressful. Is it their physiological challenges? Is it a psychological challenge? Or is it an environmentally induced issue that is leading to their mental health problem? So that is what the test will measure. It is a very robust instrument. It is a very easy to use instrument. Its administration is not at all difficult. It can be administered, explained, and solved by the individual within 10 to 15 odd minutes. So it's a very robust instrument because it's just a 20-item test. So it's quite kind of, quick in its approach. It is used, or it is made specifically to be used in a clinical setup. That is the reason why it is a short test. That is the reason why it is made easy to use, because the time that we have in a clinical setup is not much, where people can sit and get their assessments done, kind of. So it is specifically made to be used in a clinical setup. It is customized for Indian women. So when I say customized, it means that it is, we went through a very wide array of data present about the mental health conditions of women that are currently happening, etc. And from that, the kind of issues, the kind of situations that the Indian women have to go through, taking that as the baseline, this test has been created. So if this has to be used in any other country, then maybe a revised version of it might have to be made, because this is customized for Indian women. And it is, the most important part about the test is that it is a distress assessment scale. It is not a diagnostic scale. Like, say, for example, Beck's depression inventory is something that we all know about, is a diagnostic aid test. Like, if somebody scores high on the BDI, they can be safely pointed towards a diagnosis of depression. OGDMS does not provide a diagnosis of any particular mental health condition. It is a distress assessment scale. So it will show you the problem areas, like I mentioned previously. whether there's a physiological distress, a psychological distress, or an environmental distress. That is something that the test will show. That is something that the test will point towards. Based on that, the psychotherapist, the attending doctor, and the other professionals can take the assessment or can take the evaluation further. So if there is a clear indication that the person might be having psychological distress, then further assessment towards diagnosis is essential, whether that psychological distress is anxiety, whether it is depression, what have you. So OGDMS is a distress assessment. It is the first step of the diagnosis. It is not an entire diagnosis. It cannot provide an entire diagnosis. All right. So OGDMS was created, or the study for that went on for more than one and a half year, but the actual creation part took around 6 months. The study sample was of 200 females in Maharashtra. 200 females in between the ages of 18 to 60 were considered as a sample for the study establishment. There was a pilot study that had been done previously before the items were factor-analyzed, and a rough draft of it was created and then given for further administration. So before that, a pilot study was conducted, and then a final study was conducted with 200 women as the sample size. And when we look at the credentials of the establishment, so the reliability is quite high. When we look at its Cronbach's alpha coefficient, it's 0.9, so that's quite high. And the validity of the test was established in correlation with the moods and feelings questionnaire. So moods and feelings questionnaire basically assesses anxiety, depression, and other emotional issues. So like it is a baseline for mood disorders. So that was considered a good correlation for the OGDMS, because again, as I mentioned previously, this is a very unique tool. So a direct correlative test is not available anyway. That is the reason for the creation of this test. So we tried to correlate it with the closest possible partner, which is a mood disorders measurement scale. Now let's look at some of the benefits of the OGDMS. The biggest benefit, I would say, in terms of research, is that it fills a significant gap in literature. There has been no test to specifically measure distress levels in Indian women. So that literary gap has been filled by the OGDMS. So if somebody wants to use it to administer it in their setting, it is readily available. It is accurate in identifying and assessing the distresses. As I said, it is not a diagnostics tool, it is a distress measurement tool. So what area of the patient is getting affected is something that the test can very easily understand, identify, and of course report it. So if a person is showing different channels of, there's high physiological distress, high psychological distress, low environmental distress, what is it, what have you? So the array of that person's problem is very easily identified and assessed by the OGDMS. So it becomes easier to diagnose the person's problem. You get kind of a starting point, because of course, looking at the scenario currently here in India, there is a lot of stigma around mental health care. People are not very readily agreeing of the fact that there might be some kind of a psychological distress that they're going through. There might be some kind of mental health condition that is underlying their problem, or that could actually be a contributor to their physical problem as well. So like we all know that PCOS or period irregularities and so on do have a component of anxiety attached to them, which goes unnoticed, which goes undiagnosed more times than not. So for that, OGDMS is a very interesting tool, because it not only gives the healthcare provider a pointed target, but it also educates the patient in understanding themselves better. So it is a very good starting point of conversations, let's say. And the third biggest advantage of the OGDMS is enhanced patient-centered care. So as I just said, OGDMS is for assessment. It is for understanding the nature of problem that the person or that the patient might be facing. So when the healthcare providers have a better understanding of the problem, when the healthcare providers know exactly where the problem might be, it is easier to talk to the patient about it. It is easier to make the patient understand what is going on with them. It is important to it just makes conversation with the patient about their condition very easy. And it is beneficial for the doctors to know how to go ahead with that person's issues, let's say. Like, say for example, if there is somebody who is having high BP tendencies that they haven't had previously, but the cause for that is not really getting identified. Through the assessment, if we come to know that there is some kind of a psychological distress that that person might be going through, it can be further assessed and understood that, okay, this person might be going through or this person might be facing some kind of an anxiety issue, and thus the treatment can be taken ahead from there. So it is helping to enhance the patient's condition. It is helping to enhance their care. It gives the doctor a better idea, a better insight into what potentially the problems can be. So as you can see here, so the patient, the mental health care provider, and the attending physician, all three of them are kind of kept in one loop due to this measurement scale. The distress levels, the answers, or the identification that we get through this scale is going to give information to all three of them relatedly. So the mental health care provider obviously will understand where the target for therapy should be, what should be the course of action, kind of how this person should be benefiting from let's say psychotherapy, let's say any other modality of therapy, or whether they might require any medication for it or so on. So that is an easy decision to take due to the scale. The attending physician, as I just mentioned, will get an insight into the person's problem, will get an insight into how to, if there are any modifications to be made to their treatment, considering their mental health conditions as well. That will give a better insight to the attending physician, and obviously it will give more information, more insight to the patient. It will help the patient to know what it is that I am really going through. It will help them overcome their resistance or overcome their inhibition due to the stigma surrounding mental health care. It will be easier for them to seek help. It will be easier for them to receive the help that they're getting. And similarly, things will not go unnoticed, or things will not go undiagnosed, or just under the current, kind of. So that is the most important benefit, I think, of the OGDMS, that all the stakeholders involved in the patient's care, which is the patient themselves, the attending physician, and their mental health care provider, all three of them know, like it's kind of like being on the same page. Nobody has to convince nobody. It is there. It's all in pen and paper. It's all based on the information that the patient has given themselves. So it's all out there, and thus it is easier to find solutions to the problem. Now, there are, of course, a few limitations to the test, obviously, because it's a paper pencil test, and of course, because it is a test that is in English. So there are a few language restrictions also to the test. It is a single-centered design, so it was conducted only in one city, in one state. So multicultural applications have to be verified. That's something that we are looking at in the future, to conduct the test for various socio-economic groups, socio-cultural groups in India, and see whether equal amount or equally dependable results can be achieved, or if interpretations of the test or interpretations received through the test, if they are equally beneficial to the patient, the doctor, and the mental health care provider across socio-economic and socio-cultural groups. So looking at the future of the test, we are devising ways and methods to ensure that it gets used in multiple clinical setups, not just private clinics, but government hospitals, government setups, and so on, because they tend to have a bigger socio-cultural group that comes in. And we are attempting to get the test inculcated, imbibed in the system of the clinic, so that it does not become a secondary part, or it does not become a branch or a bracket of the treatment. It becomes homogeneous with the treatment, so that the patients also know that this is something that happens in the clinic. You go you come to the clinic, you get your basic case history taken, you get your OGDMS assessment form done, and then you go for your further checkup. So that streamlining is something that we have been successful in doing in a few clinics by now, a few hospitals by now, and we are looking at expanding that in the future. The impact of this test, according to me, is the advancement that it is providing in mental health assessment. This is an area that has not been explored for assessment purposes so far. OGDMS is an attempt to start that conversation. OGDMS is an attempt to start that assessment region for mental health care and obstetrics and gynecology to kind of come together. It is facilitating early intervention, because it will obviously improve the patient's care, and thus it is an attempt to promote holistic care, where the doctors, the patients, and the mental health care providers are all in it together as a team effort.
Myself, Dr. Tilagavati. I'm working as a senior resident in Department of Cardiology at Gynecology Medical College. So I proceed with my presentation. So my topic of the study is the echocardiographic evaluation of left ventricular diastolic function in antenatal women with the pregnancy-induced hypertension before and after delivery. It is a case control study. So I would like to add a few points about PAH. So as we all know, PAH is one of the most common disorders of pregnancy, which is characterized by new onset hypertension after 20 weeks of gestation. It affects 5 to 8% of pregnant women. So there are many cardiovascular changes occurring during pregnancy. The most important contribution is because of the peripheral vasodilation and a decrease in systemic vascular resistance during pregnancy. So this poses a 20% increase in cardiac output by 8 weeks of gestation, and which increases to a maximum of 30 to 50% nearing term. So preeclampsia is one of the most common specific disorders of pregnancy, which poses a risk of future hypertension, ischemic heart disease, stroke, and venous thromboembolism. So during hypertension, the heart undergoes remodeling, so which is characterized by increase in left ventricular wall thickness and mass. So this is measured by systolic and diastolic function by performing echocardiography. Usually diastolic dysfunction precedes, followed by systolic dysfunction. So diastolic dysfunction is described as impaired left ventricular filling. So preclinical diastolic dysfunction is associated with the development of future heart failure and is a predictor of all-cause mortality. So this is the main purpose of my study, so that PAH and diastolic dysfunction can be diagnosed and stratified earlier, so that PAH can be intervened earlier. So by using echocardiography, LV function is assessed by systolic and diastolic methods. The usual method to assess LV systolic function is LV ejection fraction. And the main parameters highlighted in my study is diastolic dysfunction. So based on E by A and E by E prime values. So what is E by A? E denotes the mitral inflow velocity, which is a passive filling during early part of the diastole. A denotes the later part of the atrial systole. So both this contributes LV filling. So LV filling is measured by diastolic function. So it is measured by using a pulse wave Doppler, which is a spectral Doppler, which is performed in apical 4-chamber view. So this shows the apical 4-chamber view. So this is the left atrium, this is left ventricle, this is right atrium and right ventricle. This is the mitral valve. So we are measuring mitral inflow velocities. So I am placing the sample value in the mitral valve leaflets to obtain this mitral inflow velocities. So this picture shows the E by A values. So what is E by E prime? So E prime is the peak mitral annular velocity measured in early diastole. So this is measured using Doppler imaging, tissue Doppler, which is performed in the apical views, and the sample volume is placed at the mitral annular velocities to acquire this. So this S prime is a systolic parameter and E prime, A prime are the diastolic parameter. So from this mitral inflow E value and E prime value, E by E dash ratio is obtained. So these were the normal parameters and graded accordingly. So normal E by A value is more than 0.8, grade 1 is less than 0.8, and grade 2 is more than 0.8 to less than 2. So how we differentiate normal and grade 2? By doing a Valsalva manner while performing an echo. So these are the average E by E prime values. So my aim of the study is to evaluate the left ventricular diastolic dysfunction using echocardiographic parameters like E by A and E by E prime in antenatal patients. I have taken PHS cases before and after delivery and compare it with their controls. So this is a case control study conducted in Government Gynaecological Medical College, India. And 150 patients were included. 75 were taken as cases and 75 were taken as controls. So controls were both age and gestation age matched with the cases. And assessment is done thrice. Once before delivery during 3rd trimester, next immediate postpartum period 2 to 4 days after delivery, next is 6 weeks postpartum. All antenatal patients presenting with PAH were taken as cases and normal antenatal women were taken as controls. And the patients with known chronic hypertension and known heart disease of other etiologies such as congenital heart disease, rheumatic heart disease, and ischemic were excluded. And anemia complicating pregnancy and renal disease complicating pregnancy also excluded from the study. So these are my results. So this is age-wise distribution. Cases and controls were age matched from this. So these are the baseline characteristics observed. So I have taken primary patients. Primary in cases and also in controls. All were non-smokers. And their gestational age delivery were average age is 36.2 weeks. And in controls 37.7 weeks. And birth weight of the babies were 2.42 kg in case of cases and 2.85 in controls. So LV diastolic dysfunction parameters before delivery. This shows among 75 cases, 31 had normal diastolic function and 52% had grade 1 diastolic function and 17% had grade 2 diastolic dysfunction. And among controls, all had normal LV function. So assessment during immediate postpartum, that is 2 to 4 days delivery, there is an increase in diastolic function compared with during 3rd trimester. So from 31%, it had hiked up to 40%. And 43% had grade 1 diastolic dysfunction and 17% had grade 2 diastolic dysfunction. And all controls had normal values. So by observing during 6 weeks following delivery, from 40%, 83% had normal diastolic function. That means diastolic function had improved by 6 weeks. And 5% had grade 1 diastolic dysfunction and 12% had grade 2 diastolic dysfunction. And as usual, controls had normal values. So this shows E by A ratio between cases and controls. So from this, E by A values of lower are presented in cases compared with their controls. This is E by E prime values. E by E prime values of cases have higher values compared with their controls. So this shows a statistically significant relationship between cases and controls among all the parameters assessed. So from this, what we interfere is among cases with LV diastolic dysfunction before delivery, 17 had persistent diastolic dysfunction. So among the 17% of patients 9 cases went in for peripartum cardiomyopathy. So 13 patients, that is 17% of PAH cases I have taken, they have persistent diastolic dysfunction by 6 weeks. So among these 9 cases with peripartum cardiomyopathy, all were about 30 years of age and 7 are about 33 years of age. So by systolic function, 9 cases among PPCM had poor control of blood pressure. 6 out of 9 patients, peripartum patients had poorly compliant to drugs and on irregular follow-up. So from this data, what we interfere is heart rate were higher among the cases compared to their corresponding controls. Ejection time were lower among their cases compared to their corresponding controls. So a few points about peripartum cardiomyopathy. It is an idiopathic cardiomyopathy presenting with heart failure secondary to LV systolic dysfunction towards the end of pregnancy or in the months following delivery, usually less than 6 months, when no other cause of heart failure is found. Usually ejection fraction is reduced in these patients, that is less than 45%. So this shows the incidence among various countries. The higher incidence observed among Nigeria and India. They have higher incidence of peripartum cardiomyopathy. So the first and foremost risk factor for peripartum cardiomyopathy is preeclampsia and hypertension, followed by multiple gestation like twin and or multiple pregnancies, substance abuse, anemia, asthma, presence of diabetes, and obesity and malnutrition. So peripartum cardiomyopathy usually presents by first week following delivery. This is the usual majority of cases likely to occur. So this picture shows the raised values of prolactin levels and soluble FMS like tyrosine levels among patients with the peripartum cardiomyopathy. So LV function at the time of diagnosis is the most reliable predictor of adverse events and long-term recovery. So we are measuring these values. So fortunately, there is a higher rate of recovery than other forms of cardiac failure among patients with the peripartum cardiomyopathy. Usually recovery occurs by first 3 to 6 months, but there have delayed recovery noted up to 2 years. So to conclude, there is statistically significant relationship, that is p-value less than 0.001 between E by E prime of cases and controls. So at last, E by E prime and E by E dash, which is the useful parameter to detect diastolic dysfunction in PAH patients. Hence, patients with PAH having moderate diastolic dysfunction and increased maternal age. So we observed 33 years in our study. So all these parameters needs to be closely monitored so that cardiovascular complications can be prevented or intervened earlier. So I reiterate, careful evaluation, early diagnosis of pregnancy-induced hypertension and LV diastolic dysfunction and the follow-up of these patients may help to reduce the future risk for heart failure and peripartum cardiomyopathy. So optimizing blood pressure levels, both pre and post delivery, can avoid complications like peripartum cardiomyopathy. Since we found that 9 cases with the PPCM had poorly controlled blood pressure values, out of which 6 were poorly compliant to drugs. So monitoring these BP values is appropriate to reduce the complications of cardiovascular complications of pregnancy. Yeah. These are my references. Thank you.
Good afternoon to everyone. I am Dr. Ganesh. I'm a consultant on oncogenetics and embryologist in my institute, the Jawaharlal Cancer Hospital, Bhopal. This is the only center where we practice clinical embryology in the 2 states of Madhya Pradesh. And this is something very unique finding what we have did. It is not a new, but people had practicing this since almost 30 years back. But it is not a routine practice as a clinician does, because it is something subjective, anthropometry, and validation was not there. But now we are practicing this since ages, and we give a hallmark of this kind of findings for male fertility especially. Why we have chosen this parameter? Because in routine, many gynecologists are acknowledging this platform. And they know that maximum time, many a time, the female has been examined thoroughly with all profile, everything. Very few male has been checked below the belt, and I don't know whether it's a fear psychosis of the male partner, or some rigidity from the male partner could not able to visit to the OPD or gynae OPD. Either the female gynecologist or male gynecologist is not taken in much interest to examine the male part. In my center, maximum the cases comes where male never be examined in the gynae OPD, and they referred directly to me, and we found some of the other abnormality, and we reported and we rectify also. Recently in Bangkok, I presented the rectification of this kind of abnormality, but this is something a personal domain where Palmer region counts the ATD angles and anogenital AGD, anogenital distance are one of the predictive assay where we have marked that decreased anogenital distance and abnormal Palmer triradius angle of Palmer's has been acknowledged the abnormality in chromosome and poor semen quality. It may be azoospermic, oligospermic, or cryptozoospermia, some anomaly of the shape of the head, acrosome, tail, head, and neck. But it is something we found that almost 10% of the unexplained infertility comes in the world population. WHO acknowledges this, that, and there are two type of infertility, primary and secondary. We handle both the cases in our OPD, and these are the causative factors everyone knows, but some are the hidden factors which is not much aware by the population and the couple itself. What we found that maximum of the stress induced, and now the COVID vaccine and COVID virus had induced. So many publications are there since 2020 that COVID virus and vaccine had created hell of genital disorders, especially rectal dysfunction in male and sperm abnormality in male has been reported. Even PCOD is being reported recently in 2023. One of the paper in German, they reported that PCOD are much more evidently proven in post-COVID cases in young females. And a few evidence says that tight outfits, Julia et al. Had published in 2015. She said tight undergarments, tight outfits may reported sperm counts abnormalities. And over the top, like Joseph and Daniel, they put on a note that isoflavonoids and phytoendocrines, which is present in soya products, that is glycine max, it has maximum amount of genistein and diagen. Jeff had reported, and they reported jointly that the same concept and same theory hypothesis has been made by these scientists that they interfere the male hormonal or some genetic disorders. So we have to think many a time to infuse such kind of diet, especially in gyms, whey protein being infused regularly. And to be honest, I visited so much of gym area. I did counseling. My team went there. We bought the volunteers from there, and accidentally we found azoospermic, oligospermic, cryptozoospermia in boys between the age of 16 to 30. This is something very alarming. The gym personnel must understand the importance of gym exercise. The diet must be given by the dietitian, not by the gym experts. Whey protein should not be infused in young boys. Those who are not married should not be infused with this because it's going to damage testosterone level, and sperm abnormality also got reported. And we also found evidently, I am going to show in next of the slides. Yes, diagnosis. So people do this. I don't deny that people never perform this in male, but 90% the male not been checked in our state. I'm not saying people voluntarily come, sir, we want to go for it. But when we did camp, we promote counseling, we talk about this subject. Voluntarily, the people comes and say, yes, sir, we want to check. This is a cytogenetics test we do, and one in non-invasive methods with this three things. One is D, one is InStape, and another is Mark. There is no blood, no semen, nothing. Before intervention of these invasive protocols, straight away you go for this non-invasive subjective markers, which is known as anthropometric markers. It is something very good and very easy to design, and you can randomize your trial. Please go for it. Take 1,000 of population, go for this, and you can find that how beautifully it is going to define these abnormalities. And they are not married, but take these samples if they have less anogenital distance, less than 2 inches, and if more 80 angle, more than 45 angle, please go for chromosome and semen. You'll find hell of abnormality acknowledged with this supporting anthropometric markers. Fine. What is this exactly? Redron and Hessenberg already had put on a note that this is one of the subjective measurement people do with vernier caliper, but we prefer vernier caliper have the pointed edge, may got hurt sometime, patient, generally the male feel shy to expose. But in our institute, with my counseling, the patient really supportive, and the volunteers comes and go for this, but we never prefer vernier caliper. We prefer 3 times we take a measurement, we take a mean, and then we record the data. This is a distance between anus to the scrotal base and the distance from anus to genital base. If it is less than 2 inch, means 1.99. You have to check thrice. If it is again coming 1.99, the subject must be subjected for chromosome assay and semen assay. Very simple. This is one of the case where you can see distance between NS and to scrotal and NS to genitalia base. And we did 500 cases. We did a lot of cases, but this is something very small population we want to show. It is between the age of 18 to 35. Informed consent being taken, ethical approval being taken for such a study. It is something very, it is risky also sometimes. So we have a normal group where more than 2 inch are there. Total population 302, and abnormal is 198. And where we found the abnormality is having 1.8 mean value, and mean normal values about 2 inch, that is 2.1. This is a mean of all the cases what we scored. This is another case where we had examined with this D, this anogenital, this triradius point, thinner hypothinner region. There is a point where we have to, this is the location we should get the triradius, and there are 4 triradius over here. Take pointer and the little finger triradius point and take one. This in normal healthy population, only one triradius will, one angle will be reported, and that must be below 40. I'll tell you what is the range of normal triradius angle. That is 23 to 33 is genius, 33 to 35 is above average, 35 to 40 is above average, 40 to 45 is below average, 40 to 45 to 50 is idiots, duffers, and 50 to 60 are idiots, and 60 above all malformed. You will get Down syndrome, all trisomies, all Turners, Klinefelter, super females, all females angles they find above 60. But we, on an average, we must have down to 40 angle itself. Is only one angle is necessary? Yes. Both the angle, both the hand, only single angle should be there, should be less than 40. If the angle is more than 40, you have to record. If one palm, there is more than one angle, maybe 2, 3, 4. If the angle is shifted from here, it's a central shift, it is a left shift, it is a right shift. If it is such reported, then you will find the difference in their chromosome and semen counts and sperm morphology also. Towards my left, you can see there's a normal palmar count, the triradius, and this is abnormal. There is a shift, there's a left shift, and you can find this is angle was reported, is down to 40, and this is angle on an average is 75. Fine, this is the angle, and this is how we have to take. This is the normal. You can find our male is showing is just 21-year-old boy, pharmacy student, having measuring 35 degree, and this shows that it is having an angle of above average angle. Between the 33 to 35 is above average. So we had checked the IQ also. He is above average angle itself. Then this is an angle of volunteers, healthy volunteers. They came. They reported that we have normal semen volumes, and we are not checked for sperms, but still you promoted for volunteer intervention for this study. They came as a volunteer, then you can find the age of 32, and this is towards my right, which is having 60 and 39 angle. He is just 22 years old. You can find one is 78 and 143, and one is 60.3, and they have two angle. Both the angle in both the hand is shift. One in towards my left, where 78 degrees mentioned, it has a major shift, and 60.3 is also major shift. Definitely, these people going to have a big abnormality on their sperm morphology and semen quality also, and their biochemical aspects, and also their chromosome profiling. This again 49, and there is a major shift. It is the angle is 47 only, but you can find a major shift in this, and the angle is 49 is not having a major shift, but both have showing. We are predicting that they're going to have some abnormality occur in chromosome level, either they are in their enzymatic level, glutathione mainly, semen glutathione level, either in their sperm morphology. This is what the ATD you can find. Here the average angle what we have is cases is 323, we have more than 40, and 177 is less than um, uh, the 377 is more than less than 40, and rest of the angle is more than 40. And you can find the shift is the major shift in normal population is only 28, whereas in abnormal population where we reported chromosome abnormality and sperm abnormality is 103. The mean ATD you can find 35.9. It is between the average to above average angle, and the abnormal ATD was mean was 47.2. This is you can find towards my left with bluing tinge of semen. This is a normal sperm count, and towards your right you can find there's a tail curling, and amorphous head is there, and towards my down there is a double-headed sperms and tri-headed sperm with bifurcated tail. These are the abnormality we reported in higher range of ATD and less range of AGD. Those who have less anogenital distance, they have very less chance to have normal morphology of chromosome. Those who have higher degree of angle of palmar digit count, that's ATD, they have also have less chance of having normal sperm count. Maximum of the people reported hypodiploidy. We submitted a case report. We got a national award, international award. These publications, this is something very alarming. Nobody bothers to check for chromosome. They go for hormonal therapy, whatnot, like correction of vas deferentia. So many things people bother. But before invasive intervention, take a blood sample 1 ml in RPMI, very simple sodium heparin tube, and culture for 48 hours, 72 hours, and then harvest and see the chromosome. If it has some abnormality, because continuously you can find the abnormalities are there in one cycle of mitosis, second cycle of mitosis, or third cycle of mitosis, should not bother to correct, please. It's not going to work out nicely because it has already a lot of abnormalities. And this you can find the minutes are there to the lower end where we had shown hypodiploidy, hyperdiploidy. This is known as aneuploidy. Some metaphysics 46, 44, 48, so on. But they are showing minutes, a small dot where arrow had put on is an indirect evidence of DNA break is there. If it is this kind of activity happening in second phase of your mitosis, third phase is a permanent mutation. Otherwise, it is negligible. It's going to wash out in the next cycle itself if it is not permanent. Then we did karyotyping. There is a loss of chromosome reported, especially small subgroup of chromosomes are reportedly even 22 chromosome has been lost, 20 chromosome is lost. Here you can find a translocation between 22 and 9 chromosome is there. It is something, some metacentric, last some metacentric chromosome is forming. This is known as Robertson translocation and is a permanent mutation. In such condition, you wouldn't expect a baby from such individuals. We can find a deletion of 1P. There is a loss of P5. There is a addition of 5Q. in the same chromosome. You can find loss of 8, loss of 17. These are the small abnormality. Trisomy 22. You can find what I said, the small subgroup of chromosome had more involved in male infertility. Trisomy 19 you can find. These are the abnormality you can see. You can find the 17 P deletion chromosome on top. These are the abnormality when it should be, like repeatedly found in the consecutively all metaphase. If it is in one metaphase out of 100, there is no fun reporting such cases. It may be altered or malfunctioning, because when we give a drop of the cells, it blasts and may shift here and there. If such kind of mutation, such kind of metaphase abnormality being reported in other metaphase also, it is a permanent. You have to report it. There's no way. Here you can find as a bar, there is a 4 set of chromosome towards my extreme left. That is 22nd chromosome, 14, 13, and 15 chromosome association. They form a radial translocation. It is known as true Robertson translocation. They may lead to some other genetic abnormality, may lead to some cancer also. This kind of happening aplastic anemia also. So we have to search for the bone marrow instead of we are there to help the fertility uh, counters. But the thing is, on the same time, we should not miss it, whether the patient is having this abnormality, having lead of male infertility or couple infertility. We should not stop our work. We should promote to this kind of abnormality to hematologists. Then they can go for bone marrow typing, and they may get fall of aplastic anemia. Fine. Same way you can find karyotyping and go, and there is a DD maximum this D and G group abnormality. You report, as I told, a small subgroup chromosome are involved. We did some experiment where you can find 1 minute. Yeah. This is a normal sperm. We had given the dietary intervention. Those who want to know about what are the diet we will give, we may call me. May refer to me the cases. This is something very good with no medication, no hormonal therapy, no nothing allopathic or any other Ayurvedic medication intervention was there. But we had given a home remedy with the dietary management. They can cook, they can eat. Everyone, one or the other way, they eat this kind of diets. But whether how to take is more important. What are the formula that we design and for the individual male, and we give. This is a normal male sperm. This is the case number 1 where you can find it's a post-COVID. He came because he had in living relation. Then he found some erectile dysfunction, and he came, sir, I want to check for. He himself came by seeing our message through Facebook and WhatsApp, Instagram. He came, he was just 21-year-old boy, engineering college student from local university. And he shocked, I shocked, because something cryptozoospermia was reported. And then we did exercise. We had taught acupressure, we had given a dietary management, and this is a day 15th sperm. The sperm has been rejuvenated, and you can find a day 45th report. Maximum of the sperm being activated. We did this cytological smear also. We initial times we found some abnormality of the head, pinhead chromosome, sperms and curly tails. Pinhead still persists little, but the normal identity of the sperm has been activated in this individual, and he is very happy. And this is what we serve. This case number 2, where you can see a case of one teacher is just 32, came with pus. He reported infertility. When we took the semen sampling, we did microscopy, video microscopy. You can find a white patch, round patch. This is a pus cells, and this is something we required antibiotic. So we thought not to give antibiotic. We have the course of this. Those who dead sperms, we would like to regenerate. We never thought that diet is going to work as very nice. Is going to remove these pus cells. You can find day 45th. This sperm has been nicely activated. and there's no pus cells in this report. Case number 3, this a case of 23-year-old blood cancer patient where azoospermic being reported after 2 chemotherapy. Doctor says that you must take, the father has been advised, please store or preserve his sperm, the sperm bank before induction of the chemotherapy, but he has not listened, overlooked. After second chemo, the doctor personally from Tata Memorial and Safi Hospital asked whether you did this sperm banking or not. They refused. Dr. Mahmood Basade from Safi Hospital is the director and head department of medical oncology. He said, better you go to Dr. Ganesh and he may have some diet which is going to improve it. This is what we did. On day 3rd, we activated the.
Sir, I'd
Just,
like to remind you that you're 20 minutes.
Yeah, it's fine. And this is another case with azoospermic, and you can find the sperm being activated. It's not working. It's not video is not supporting, but sperm is being activated. This is what we would like to acknowledge, that we should not miss this non-invasive diagnostic tool, especially the HD, ATD in male fertility issue, especially. We can say millions, the family with the depression and agony and pain. Instead of giving loneliness, we can provide a one single child which is healthy to these couples. So please come together, join hand with us for this mission to help male fertility issue. Thank you.
So my paper is on relation between serum hormones and semen parameters in subfertile males. Is 17-hydroxyprogesterone really a game changer? I'm Dr. Archie from the Institute of Reproductive Medicine and Women's Health, Madras Medical Mission Hospital, Chennai, India. Next slide, please. So as we all know, follicle stimulating hormone or FSH initiates the process of spermatogenesis in males, and luteinizing hormone stimulates Leydig cells to secrete testosterone, which sustains spermatogenesis. Estradiol is also important for modulating libido, erectile function, and spermatogenesis in males. Currently, the initial diagnostic testing for the infertile male includes semen analysis plus hormonal evaluation in the form of FSH, total testosterone, and estradiol levels. Next slide, please. So, recently the concept of intertesticular testosterone has come up, where it is saying that the serum testosterone is not a very good reflection of the actual intertesticular testosterone levels, which is of the order of 50 to 200 times than that of the serum testosterone. And spermatogenesis is severely compromised when intertesticular testosterone levels decline. The traditional methods of measuring intertesticular testosterone are invasive testicular biopsy or aspiration. So 17-hydroxyprogesterone, which is an intermediate in the production of testosterone from cholesterol, has recently been demonstrated as a reliable biomarker of intertesticular testosterone. Next. So the objective of our study was to determine an association between different serum biomarkers and baseline semen parameters in males presenting with subfertility. Next. So our study was a retrospective analytical study performed in the Institute of Reproductive Medicine, Madras Medical Mission, over a period of 18 months, that is July 2022 to December 2023. And all male patients who came to our OPD for the treatment of subfertility during the aforementioned time period were included. Next. So exclusion criteria were men with other endocrinopathies like thyroid disease, hyperprolactinemia, diabetes, Cushing's disease, congenital adrenal hyperplasia, or men on current or previous medical treatment for infertility. The sample size was 74 patients. Semen samples were collected after 2 to 7 days of sexual abstinence and examined following 30 minutes of liquefaction at 37 degrees Celsius by the same andrologist according to the WHO Semen Analysis Manual 6th edition. Serum biomarkers were evaluated from morning blood samples drawn at the same lab between 8 a.m. to 10 a.m. Next. These are the demographic characteristics of our patients. Age group of the patients was from 27 to 55 years with a mean of 35.6 years and a standard deviation of 6.3 years. And the BMI ranged from 18.7 to 42.5 kg per meter square with a mean of 28.5. Normal semen analysis was defined as having values of all the parameters above the 5th percentile values of fertile men as given in the WHO Semen Analysis Manual 6th edition. Out of the total 74 patients, only 10 had normal semen analysis, whereas 64 patients had abnormality in at least one semen parameter. Next. The mean and the standard deviations of 17-hydroxyprogesterone, FSH, total testosterone, estradiol, and T/E2 ratio were compared in the normal versus abnormal group. As we can see from the table, testosterone and testosterone by estradiol ratio only had significant association with normozoospermia, that is a considerable difference between the normal and the abnormal groups. Next, please. So then we subclassified each of the parameters like volume, count, concentration, motility, progressive motility, morphology, and pH into normal and abnormal based on above or below the 5th percentile values of fertile men given in WHO Semen Analysis Manual 6th edition and compared the mean and standard deviations of each hormone in each group. Next, please. So this is a distribution of the individual semen parameters in our study population. For volume, in the low volume group, there were 15 patients. In normal volume, there were 59 patients. For count, low count, there were 42 patients. Normal count, there were 32 patients. For motility, normal total motility was seen in 38 patients and low total motility was in 36 patients. For pH, normal was in 49 patients, abnormal was in 25 patients. For progressive motility, normal was in 37 patients, low was in 37 patients. For morphology, normal morphology was seen in 14 patients, whereas abnormal morphology was seen in 60 patients. Next slide, please. Next, please. Okay, so this is the master chart showing the relation between each semen parameter and the serum hormones. Here we have divided each parameter like count, volume, concentration, motility, morphology, and pH into low and normal, and then we have compared the mean and the standard deviation of each of the hormones in each group. And there we have derived an association of FSH with sperm count and total motility, total testosterone with sperm count, semen volume, sperm concentration, total motility, progressive motility, and morphology, and T/E2 ratio with sperm count, volume, and total motility, progressive motility, and morphology. Next, please. So, as we can see, serum FSH showed significant association with sperm count, concentration, and motility. P less than 0.05, and sperm testosterone was significantly associated with sperm count, semen volume, concentration, total motility, progressive motility, and sperm morphology. But serum 17-hydroxyprogesterone, the molecule we were looking for, and estradiol were not found to have any statistically significant association with any semen parameters. Next, please. So kind of we were a little upset that because 17-OHP did not show any result. But when we went back to the master chart, we suddenly saw a trend where in our study population, 61 patients had normal 17-OHP levels, which is 0.55 to 2 nanogram per ml, whereas 13 patients, that is 17.5%, had low 17-OHP level, that is less than 0.55 nanogram per ml. As we can see from the table, when we compared the trend of the sexual dysfunction amongst these two groups, we saw that some sort of male sexual dysfunction was present in 6 out of 13 patients in the low 17-hydroxyprogesterone group, whereas male sexual dysfunction was present only in 9 out of 61 patients, that is 14% patients in the normal 17-OHP group. So the odds of having sexual dysfunction in the low 17-OHP group comes out to be 4.95. And the p-value of the association is 0.01, which is also significant. Next, please. We had 9 patients with non-obstructive azoospermia in our study, whom we treated with 3 months of medical therapy in the form of gonadotropins, clomiphene-cited or aromatase inhibitors, and followed up with a repeat semen analysis after 3 months. Then we classified the non-azoospermic patients into low and normal 17-OHP group. In the low 17-OHP group, 3 patients were there with non-obstructive azoospermia, while in the normal 17-OHP group, there were 6 patients. We compared the semen analysis after treatment in these 2 groups. In the low 17-OHP group, semen analysis after treatment improved in 2 out of 3 patients, while in the normal 17-OHP group, it improved only in 1 out of the 6 patients. The odds of improvement came out to be 10, but the p-value was 0.133, which is not significant. Next, please. So, coming to the discussion, according to the Lima et al., serum 17-OHP appears to be a reliable serum marker for intertesticular testosterone levels. Our study found statistically higher prevalence of sexual dysfunction like erectile dysfunction, premature ejaculation, hypoactive sexual desire in men with low 17-OHP levels, that is less than 0.55 nanogram per ml, which might be related to low intertesticular testosterone levels. Pinkas et al. Concluded there was no correlation between serum 17-OHP level and the baseline semen parameters, and we had quite similar findings in our study. Next. So another article by Lima et al. Said that medical therapy for infertile men with testicular dysfunction resulted in improvement of sperm concentration, total motile sperm count, testosterone, and 17-hydroxyprogesterone. Semen quality upgrading appeared to be more significant in patients with low 17-OHP in their study, suggesting that it can be used as a biomarker to predict semen parameter improvement. In our study, taking their threshold of 0.55 nanogram per ml value of 17-OHP did show odds of improvement of semen parameters in patients with non-obstructive azoospermia, but it was not statistically significant, probably due to very low sample size of just 9 patients. Next, please. So the limitations of our study were the shorter duration of the study, the limited number of study subjects, and a single center study. Next, please. So to conclude, 17-hydroxyprogesterone is definitely not superior to FSH and testosterone, which are conventionally used in subfertile males as a predictive factor for baseline semen parameters. But what we found new in our study was that our serum 17-OHP level can function as a promising novel marker for male sexual dysfunction. Low 17-OHP, that is less than 0.55 nanogram per ml, did show some sorts of improvement of semen parameters in patients with medical treatment, but it was not statistically significant, probably due to the very low sample size. So to predict whether 17-OHP can actually predict improvement of clinical outcomes after medical management, as shown in some previous studies, a study with more patients and a longer duration of follow-up is needed. Next. So these are my references. Thank you very much.
Hello everybody, I'm Khalaf from Iraq, from Al Nahrain University, Baghdad, and Kirkuk University in Kirkuk. Today, the subject of mine is the effect of letrozole on the hyaluronic acid concentration of the endometrial wash. So as we know, the cause, excuse me, the next slide, or should I make the next from myself? Thank you. The infertility, as we know, have a lot of causes. Its definition is that failure to achieve pregnancy after 1 year of regular unprotected intercourse for women under 35 years old, and for 6 months whom those over the 35 years. And there is a lot of affect the young men and women. And these days, the infertility is increased in percentage and all over the world. Next slide, please. The causes of the infertility is, as we know, male and female causes, and combined and unexplained. For the male causes are, it is either pituitary or gonadal or sperm transport disorder or unknown causes, while the female is could be the defect in the ovulation or the transport or the defect in the endometrium. Next, please. As we know, the risk factor, there is a lot of articles discussing the risk factor for the infertility, while the most non-factors is the age, smoking, drugs, the overweight, diet, physical activity, caffeine use, and psychological stress. Next, please. Next slide, please. I think it is very slow, like getting in my position right here. Next, please. Because the next slide is about the risk factor. Next, yes, this one. Okay, next slide, please. Next one. Yes. The endometrial receptivity, as we know, is defined as the temporary unique sequence of factors that make the endometrium receptive and conductive to the embryonic implantation. There is a lot of receptors and substances affected the endometrial receptivity, like endometrial steroid receptor for the progesterone, and estrogen receptor, which is important for the implantation of the embryo into the endometrium. Next slide, please. These other factors is the endometrial growth factor and immune markers, hormonal influences, genetics affecting endometrial, it's special ligands that affecting the genetic factors, which has a role in the endometrial receptivity. Also the endometrial contraception, which means also the hormonal influences is same. And histological marker, it's like the other substances like integrin, mucin, and others. Next, please. The implantation window, which is conductive blastocyst and acceptance of the endometrium into the embryo implantation, it is about lasts for 4 days. For 4 days also after the ovulation. It's about 6 to 10 post-ovulation days, and the window lasting for approximately 4 days from day 20 to 24 of the cycle. And nowadays there is a lot of tests doing for concentrate about the implantation window for the success of the IVF and getting good results by taking the good day for the implantation of the embryo into the endometrium. And one of these tests is the ERA, which is about 3 to 4 years we work on it, and it's study about 238 genes, suggesting that give a result for approximately which days that can the endometrium be receptive to the blastocyst, and that make the IVF more successful or the exit. Next slide, please. The hyaluronic acid is is an anion non-sulfated glucose unique among the glycosaminoglycans in that it is non-sulfated form in the plasma membrane instead of the Golgi apparatus, and it's important in the proliferation and migration. Next slide. The hyaluronic acid is a glue-like molecules that it is ubiquitous carbohydrate and it is, as we said, spread in all over the tissue, all over the body. That is a part of the extracellular matrix. And for example, hyaluronic acid is the major component of the synovial fluid and found and increase the viscosity of these fluids. Next slide. The benefit of the hyaluronic acid is all over the body, so it's important in the granulation tissue and wound repair, healing process by its cell migration through over the body from extracellular matrix. So it is very important. That's why it is used in a lot of medical uses, like the intra-articular injection. Next slide, please. Intra-articular injection, the eye drops, the cosmetic cream and cosmetic serums, and also in the filler injection in the dermatology and cosmetic aesthetic branches. Hyaluronic acid also, it's important in the infertility. So it is the transfer media. It's based on several properties that characterize it is an implantation changing molecule. Next slide, please. So its viscosity is believed that it's facilitate the integration of the embryo into the fluid secretion of the uterine environment, as it has been shown to increase cell-to-cell to the matrix adhesion, and the presence of the CD44 receptors for the hyaluronic acid in addition to the HAS1 and 2, these are hyaluronic acid receptor expressed on both embryo and the supporting network of the human endometrium, suggesting that it acts on during the process of the implantation. Next slide, please. So here is the diagram discussing the hyaluronic acid and its presence and its receptors, how it induces the migration of the cell, which can make the blastocyst more conductive to the endometrium. So here we can see, can you just press next to see the receptors on the diagram, please? These receptors, which has 1, 2, 3, and hyaluronic acid 2, CD44, and other, yes, thank you. And these are the migration, also helps to the migration of the cell with the progesterone receptors, which make, and interferon and other cytokines, make the blastocyst more conductive to the endometrium. Next slide. The hyaluronic acid in reproductive biology and clinical application is gaining an increased recognition in and hyaluronic expansion of the camulus cell at the ovulation and the induction of the cervical ripening during the parturition are well documented. And treatment of the over-rectomized mice with progesterone increase the uterine hyaluronic acid concentration. Next slide. Our study is a comparative study that is done in the High Institute of Infertility in the Al Nahrain University in Baghdad, and it's a High Institute of Fertility Diagnosis and Assisted Reproductive Technique clinic. We take a lot of patients. Next, please. Which inclusion criteria of this patient was a patient in reproductive age between 20 and 40. Next, please. And with regular menstrual cycle. And those patients was suffering from primary or secondary infertility with different causes and with normal ovaries reserve as documented by hormonal assay and antral follicle count. Also with patent fallopian tubes, which is documented by doing hysterosalpingograph or abdominal laparoscope, normal semen parameter of the male partner. While the exclusion criteria is women in less than 20 or over 40, female has any abnormality in the genital tract, tubal obstruction, unilateral or bilateral, females who have hydrosalpinx or male factor, also female with type of any type of ovarian cyst or any masses in the endometrium, female with endocrine disorder like thyroid dysfunction. Next slide, please. Next, yes. Examination is done by body mass index, full clinical gynecological exam, and ultrasound examination with seminal fluid analysis. 20% undergo ovarian stimulation with letrozole plus follicular stimulating hormone, and the others control with no stimulation. Ultrasound confirmation of the follicular maturation, stimulated or natural. Also, blood will be taken for hormonal estimation for luteinizing hormone and estradiol, progesterone, and hyaluronic acid concentration measured by taking the endometrial wash sample. Next, please. Catheter, 3 ml of sterile disposable syringe with normal saline attached to the IUI catheter. Then inject this 3 ml of normal saline solution after 3 seconds, aspirate the endometrial lavage. After that, sample collecting, centrifuging, and take the supernatant and evaluate the hyaluronic acid concentration by using the ELISA kit. Next, please. The is standard curve was created by plotting the mean absorbance for each standard on the x-axis against the line of y-axis and draw the best curve through these 2 points. Next slide. The trigger is done between 11 and 14 days by injection of 10,000 international units of human chorionic gonadotrophin injection. And the result was taken. Next slide, please. Next. This is the general characters of female collecting the study, which is found that residency and from rural or urban area, and the age group, the mean taken and the parity, and duration of the infertility by years. So we see here the numbers and the percentage. The comparison of hormonal of luteinizing hormone estradiol and progesterone among these females. Here we take another group which received clomid with FSH, while the A group is receiving letrozole with FSH, and both groups seen that the p-value for the first group, which is using the LH, especially for the E2 and progesterone, and we know that these two hormones are very important for the implantation and the success of the implantation process. It is highly significant in the A group, which are receiving the letrozole with FSH. Next slide, please. The level of hyaluronic acid and in the study group with the correlation between the hyaluronic acid and LH group and the A group, which are receiving the letrozole, seems that the LH is not highly increasing, and which is very beneficial during the LH search after the ovulation, and this is seen that the correlation between the hyaluronic acid and the trigger day in the group A, which are receiving the letrozole. Next, please. The correlation between the hyaluronic acid and LH of the group using letrozole at the day of trigger between the group using the letrozole group, which are using the clone, synchronization between the ovulatory function and the endometrial thickness. So there is a high correlation between the LH, between the hyaluronic acid and the LH and the clomiphene straight using group, while it is a plateau and the group A are receiving the letrozole. Next, please. The correlation between the hyaluronic acid and at the day of it's better in the letrozole group. Next, please. This is the correlation between the hyaluronic acid and the progesterone. Also, it is very better, as we said, in the letrozole between the hyaluronic and progesterone at the day of trigger and the group which receiving the clomiphene. Next, please. Also, the correlation between the hyaluronic acid and the number of follicles, so which is unexpected results. It seems that it is better in the letrozole receiving groups. Next slide. The hyaluronic acid and endometrial thickness in the two study groups, it seems that the endometrial thickness better correlated between the hyaluronic acid and the thickness in the group which receiving the letrozole, while it is plateau in the group which receiving the clomiphene straight. Next, please. The correlation between hyaluronic acid and the prima index, there is no correlation between the both groups. The pregnancy rate in the study group, next slide, please. The pregnancy rate between these two groups seems that it is better in the group that receiving induction of ovulation, while it is a lower pregnancy rate in the control group. As we see here, that the positive, it is 45% for first group, and it is 55% for the other group. Next slide, please. This is the hyaluronic acid with the stimulation outcome. it seems that the study case is high with the pregnancy and the hyaluronic acid with the stimulation outcome. So it is higher if it is compared with the control group. And also here the other diagram, which is the relation of the hyaluronic acid with the pregnancy rate in each stimulating group. So the first one is the group which is receiving the letrozole, while the other column, it's comparison it with the control group. Next slide. Our conclusions here that the hyaluronic acid was elevated significantly in women who received the ovulation stimulation drug, and the positive correlation between the hyaluronic acid and luteinizing hormone at the day of trigger of ovulation in women receiving plus FSH. There is a positive correlation between hyaluronic acid and progesterone at the day of the trigger in women who receive the letrozole. Also, next please. Also, there is a positive correlation of hyaluronic acid with number of follicles and endometrial thickness in women after receiving the letrozole, and a high pregnancy rate was higher but statistically not significant in female receiving the letrozole, followed by those who treated with clomiphene, and then the control group in the last place. The study revealed that hyaluronic acid concentration was significantly elevated in women who became pregnant compared with non-pregnant women, mainly in the group that receiving the letrozole with FSH. And the presenting study found that the letrozole was superior to the clomiphene steroid as a treatment for the anovulatory infertility. The next slide is our happy and sad stories in our study here. Can you show us the next slides, please? Also, we have triplets and twins. And thank you for listening and much.
Hello, dear colleagues, dear listeners. My name is Kartpaeva Janel, and I'm the first year resident of the Department of Obstetrics and Gynecology in Astana in Kazakhstan. The topic of my report, which I'm going to present you, is active drainage of postoperative wound as a method for the prevention of complications in postoperative women in the postoperative period. Let's start from introduction. Complications of a postoperative wound during cesarean section, such as seroma, hematoma with possible subsequent abscess formation, are one of the actual problems of modern obstetrics due to the deterioration of the healing process of a postoperative wound, an increase in the length of stay of postpartum women in the hospital, and an increase in the cost of the treated case. Predisposing factors are disturbance in the blood supply to the skin subcutaneous fat flap, formation of large residual cavities, impaired immune status, presence of pronounced subcutaneous fat, and the duration of surgery. Drainage is a traditional element of the treatment of postoperative wounds. Evacuation of wound exudate helps accelerate regeneration process. There are primarily results of the early drainage method on day 1 to 3 after cesarean section, but taking into account the risk of infection with each attempt at seroma aspiration, we have developed an active drainage method for the prevention of complications in postoperative women with high risk of developing postoperative wound complications. Objective to determine the indication of the use of active drainage of a postoperative wound at the stage of cesarean section. The first task to conduct a retrospective analysis of treated cases with postoperative complications as seroma, hematoma, and infiltrate. The second task to identify a risk group of postpartum women with the development of postoperative complications in order to determine the indications for active drainage during cesarean section. And the last one, analysis of the results obtained after active drainage. Materials and methods. The authors conducted a retrospective analysis of the medical histories of 60 women in the postoperative period. The main group, women, so which the method of early postoperative drainage was carried out in 1 to 3 days. The control group, 30 women who underwent active drainage during cesarean section. An analysis of the medical history was made for the period from June to December 2023 on the basis of the obstetric block of the State Medical Hospital number 2 in Astana. To evaluate analytical data, we have compiled checklists. There are patient's name, age, medical history number, birth period, diagnosis before surgery, planned or emergency, duration of surgery, blood loss, skin incision, methods of suturing the skin incision, on what day was discharged or transferred, intraoperative complications, and the postoperative diagnosis. The following risk factors for the development of postoperative complications are identified. There are prenatal rupture of membranes, preterm prenatal premature rupture of membranes, placental abruption, bleeding, presence of adhesions, overweight, diabetes, arterial hypertension, and preeclampsia. As you can see in the table, the description of the risk factors was almost the same in both groups of patients. And the diagnosed complications of postoperative found in the main group, seroma detected in 30% of women. There are 9 women. Infiltrate detected in 5 women. Hematoma in 2 women. The figures for the control group were much lower. The seroma detected in 2 women, infiltrate in 1 woman, and the hematoma was not detected. In the first picture, you can see the seroma. Seroma, it's a process of early drainage method, and this is the second day of after surgery. In the second picture, is here the first day after surgery. Here is the process of early drainage too, and here you can see the socket napkins. After this, and the third picture is the third day after surgery. We detected the complication as there is a hematoma. Here, active wound drainage is the process of using special half tubes to remove biological fluid from the wound bed. We offer for use a drainage system made of polyvinyl chloride. Here you can see the process of preparing active drainage system, how we can divide it and use it for the drainage. In the picture 5, there is the first day after surgery. Here we have socket napkins in the first day, and we if there are indicators, we leave drainage in the first day. As you can see, we have received confirmation for the successful use of these methods in the form of a copyright patent and the act of implementation. The discharge was made for the day for the main group from 5 to 9 days, for the control group from 3 to 5 days. For information, according to the clinic protocol of the Ministry of Health of the Republic Kazakhstan, discharge for 4 to 5 days. We can see that in the control group, wound healing occurs much faster. So, all in all, indications for active drainage are infectious, hemorrhagic, extragenital, intraoperative complications, emergency cesarean section, presence of chronic foci of infection, excess body weight. And the results, retrospective analysis of treated cases with postoperative complications reveals the need in the preoperative period to assess risk factors by the operating surgeon in order to determine the indications for active drainage of the postoperative wound. Risk groups for the development of postoperative complications have been identified, which are an indication for the preventive methods of active drainage of a postoperative wound. The use of the active drainage method made it possible to significantly reduce the risk of postoperative work in postpartum women. Thank you all for your attention. If you have any questions, you can text me on my email.